Hello, everyone. It's a pleasure being here today for this Master Days in the Minimal Invasive Surgical Treatment of Atrial Fibrillation. And thanks to the Society and to Nico, with whom I work on this program. And it's a pleasure having Dr. Damian here co-chairing as well. And I'll start maybe introducing Dr. Glover, who is my colleague in Canada, and he's the head of the arrhythmia service at Queen's University. And I think it's very nice to have the also presence of EPs in this very changing world of ablation and potential hybrid procedures. Ben?
Thank you very much. So I just wanted to give a quick overview of complex cardiac mapping in 10 minutes, which is difficult because this is what I spend my entire life doing. But I think that the value of this is that it shows us that it's not just anatomically driven ablation, it's also looking at substrate and mechanisms of arrhythmias. We perform around about 440 ablations per year, of which about 50% of them are complex and the rest are non-complex. We use three main mapping systems, the Cardial, which would be the main system which is used throughout the world, which is Biosense, Precision, which is St. Jude, now Abbott technology, which is a new mapping system which has only been available within the last 6 or 7 months, and Boston Scientific Rhythmia, which is probably the most evolving technology in terms of mapping that we have. And I just wanted to run through how we map our arrhythmias in the lab. We've always divided mapping systems up into magnetic-based and impedance-based. Traditionally, Cardial was considered to be magnetic-based, and St. Jude was considered to be impedance or current-based. Actually, they've now all become hybrids, so they're a combination of both magnetic and impedance, which gives advantages of both. In general, magnetic technology is very accurate. You've usually got an accuracy of about 1 millimeter of your catheter localization. Whereas the advantage of impedance-based is that you can actually see any catheter in the body. It doesn't have to have a magnetic sensor in it. So all systems essentially are coming together and using both technologies. So all of my ablations that I perform are endocardial from the groin. We're setting up a hybrid program at the moment. But in general, for an AF ablation, I use a catheter in the coronary sinus and do 2 separate transeptal punctures. We've got an ablation catheter here in the left atrium, second transeptal puncture under fluoroscopic and TE guidance. Slide it into the left atrium. And then we begin to acquire our data. So this is Cardial, and essentially we're starting to move the catheter around in the left atrium. This is a lasso or a spiral-shaped catheter. And this is real time, so to acquire very detailed anatomy of the left atrium takes about 10 to 15 minutes at most. We can move the image around so we can see it in different views. We've got our circular catheter, which is acquiring almost all the anatomical data, and we've got our ablation catheter, which is sitting in the left superior pulmonary vein. And this is as we get a little bit more information, a posterior view of the left atrium. We can see we've got, I think, very accurate anatomy, which is what we expect almost for all cases. We have traditionally done CTs or MRIs of patients' left atrium before ablations. We've actually found more recently that because the data that we collect from our mapping systems is so accurate that we probably don't really need the information, but in this case we'll just show you how we merge the CT and the FAM, the fast anatomic map of the left atrium, just for accuracy. Again, this is all live, so this is what's happened really in the EP lab. And it looks pretty good. I mean, you're never going to get a 100% match. I actually think the map that we get on the day is more accurate. The CT is usually done a day before when the patient's either in a different rhythm sometimes, or else a slightly different hydration status, but this looks, pretty accurate. And then we can clip the images so that we can see, essentially on the left-hand side, we can see inside the heart. It's an internal view. And on the right-hand side, an external view. So we always work on 2 different views so we can get a good idea of the 3-dimensional anatomy. We do all have contact force now in all of our catheters. So essentially we can tell in terms of grams. We can see here 7 grams. We can tell how much force we're applying, and in general we like to apply at least 10 grams, which we think may result in a transmural lesion, although this obviously differs according to the thickness of the left atrial wall. So that's Cardo. Precision is a slightly different system. This is from Abbott or St. Jude Medical. This is a new system. The prior velocity system we don't use any longer, and we've been using this since November. We were the first centre in North America to use this. Obviously, it was used in Europe before North America. And again, we can see an internal view with the ablation catheter and the spiral catheter in the left superior pulmonary vein, with the ridge, the Coumadin ridge here, and the left atrial appendage here. And we have colour codes according to the lesion, so we look for different parameters, not just contact force, but duration and different indices to see whether we have a good complete lesion or not. And we can also do epicardial mapping. This was a subxiphoid epicardial map of the left and right ventricle. The green lines are impedance points, the orange lines are magnetic points. And actually we can get a very accurate map, and this is very fast. This takes around about 15 to 20 minutes. Rhythmia is I guess the latest system which we use. This is very, very, very rapid. It collects thousands of points within a few minutes. This map took around about 15 minutes. It's the electrode, the catheter that we use to map is 64 electrodes, so it acquires a lot of data. And this was a patient who had a recurrence of atrial fibrillation after a first time pulmonary vein isolation. And just on these 2 images, we can actually see exactly where the breakthroughs were in the lesions. There's a breakthrough coming through here, just slightly anterior to the right superior pulmonary vein, and a breakthrough here, which was just at the inferior aspect of the left inferior pulmonary vein. So this map took virtually no time to make, and we've already found where the 2 lesions lie. And this took 1 burn in each location to get complete isolation. And we could remap and prove this within another 10 or 15 minutes. Again, this is another very high resolution map from Rhythmia, which shows a CTI line, a Catheter Cuspid Isthmus ablation for right atrial flutter. And we can see there's a slow area of conduction through the line. The line's almost intact. There's a little gap here. 1 burn, and we were able to cause block of this line. So this is very, very useful information if you're trying to prove block across a line. And the last kind of Rhythmia image was a mitral isthmus dependent flutter. We can see it kind of goes from early, which is red, yellow, green, blue, purple. So we can see it's going counterclockwise around the mitral annulus, and this is treated with a mitral isthmus ablation line. There are several other mapping systems I'm going to spend literally 2 minutes on, and this is really to try and understand the mechanism of persistent atrial fibrillation. This is a system which uses a vest, a multi-electrode vest, looking at rotors, if you believe in rotors, and this shows some supposed rotor activity in the posterior wall of the left atrium. And this works actually. They've tried this out in Bordeaux. I spent some time in Bordeaux, and I've seen it firsthand. This system actually works. It's superimposed between a vest and a CT scan. This is a seizure-inducing slide, but this is a multi-electrode catheter within the right and left atrium using a slightly different technology with 2 basket catheters, one in the right atrium, one in the left atrium. And again, this is supposed to show a potential mechanism of rotors within the right and left atrium, which if targeted may result in termination of atrial fibrillation. This is still very, very controversial, and the results are extremely controversial at this moment in time. My personal belief is that we don't fully understand the mechanism, nor can we map the mechanism in terms of persistent atrial fibrillation at this time. This is some work that we've done in Queen's looking at intracardiac electrograms in the left atrium for the treatment of persistent atrial fibrillation. Sometimes we get termination of persistent AFib just when we do a pulmonary vein isolation, and we think that perhaps we may transect a rotor There's many other reasons why this may happen, but this is looking at dominant frequency and wave break. In other words, we're looking to see high frequency areas which may represent the center of a rotor, and low wave break which may indicate stability of a rotor. And when we ablate in these areas, we have a termination of AFib. This is still experimental, and this is the kind of the last thing that I'm interested in, which is catheter development. And this is a catheter that we're currently developing using some gold nanoparticles. My true belief is that the mapping systems are only as good as the information which you input. So if we have better catheters with more data, we may actually be able to understand atrial fibrillation to a higher level. So this is what we're kind of working on at this moment in time. In terms of overall conclusions, in terms of mapping, what we want as electrophysiologists, what you want as arrhythmia surgeons, is something which is fast, which is high resolution, which gives you a lot of dense points, and which self-annotates. I didn't have time to get into it, but a lot of these systems now essentially are thinking for themselves, so there's less individual error for technicians to put the points in the wrong spots. So these are becoming self-annotated, rapid, high-density systems, which are very, very useful for the ablation of atrial fibrillation and other arrhythmias. Thank you very much.